Dr. Gewillig, welcome, Mark. I think we're continuing on the valve theme, but a valve in a different position. Welcome.
Indeed. So topic of my talk is pulmonary valve. These are my disclosures. And the patient I'll be talking about
Can we get the slides, please?
The patient I'll be talking about is a now 13-year-old patient, tetralogy of Fallot. In the old days, we thought we could make the outflow tract grow and escape a transannular patch. Obviously, in this patient, it didn't. So he did get a small transannular patch, and at the age of 12, he did present with significant PR, some TR, decreasing exercise level, and then the echo. Actually, the most important thing that in the echo that we measure is the outflow tract, which at maximal dilation is about 22. And here you see the MRI, which shows a significant dilated right ventricle. I think it's exaggerated slightly. Still good function and significant pulmonary regurgitation. I mean, as you see over here, free-floating pulmonary regurgitation. So the intended procedure is a percutaneous.
Mark?
Yes?
Mark, stop. Mario? Kevin? Be quick. So, what you're going to do for a landing? Or first of all,
Yes.
do you agree with Mario? Do you agree with going ahead with this case?
Well, a decision is made of putting a valve in, and of course you have a free regurgitation. You need a good and appropriate landing zone to put a valve in.
So the indications are secure for you.
Well, I wonder if we can wait for a longer time for this patient, which is rather young, and followed by CP test or MRI and see whether this regurgitation can be tolerated longer. But certainly there's if the number of 200 mils per square meter is right, it's a pretty large right ventricle.
Kevin?
Well, he's 12, isn't he, Mark? So I think it's reasonable. The trouble is we're starting on a continuing journey with this patient with multiple valves over their lifetime, and whether deferring it another 5 or 10 years would turn out to be better, hard to know. We know the right ventricle will look tons better once you've got a valve in, but there's a real price to pay.
So Kevin, you want to wait? We've got 200 mils per meter squared right ventricular end diastolic volume, and you'd still wait, would you?
12 is still really quite young to begin on the valve route. We no doubt we've gone early from many years ago, and there were a number of patients we regretted putting surgical valves in early on, that we created more trouble than the patient had before.
Lee, I can hear you mumbling.
May I make another comment on that? I mean, the problem is that we don't know the clear-cut answer to enlarged right ventricle in tetralogy repair. There are some patients who can tolerate for years an enlarged right ventricle, and there are others that will crash. And you reach the point when you decide to put the valve in, it's late, it's too late. We still don't have the clear-cut answer, the timing of putting a valve in, actually.
Okay, Giacomo. Thank you, Kevin.
Well, I don't know what the weight of the patient was, but in our place, this patient would certainly get the valve. And by transcatheter intervention, if the patient was enough for accepting the delivery sheath, or by surgery if the patient was too small for intervention.
Giacomo, just before you go, at 21.8 millimeters of pulsatile RVOT, what valve would you be thinking of putting in?
Well, our policy is to implant a stent and leave it there for a couple of months, and then go with a covered CP stent, and over the CP stent implant in this case we probably will implant a 23 EDOS valve.
Thank you.
Okay. So we decided to go ahead and put in a valve, and indeed...
Actually, can we just have a straw poll? How many people feel this patient needs a pulmonary valve replacement? Yeah. How many people feel that the patient, should we even say this, should have the valve done transcatheter? If it can be done transcatheter. How many people feel it can be done via transcatheter route? Okay. Will anybody put their hand up for surgery? Oh, this is, Joe Giovanni's put both his hands up. Okay.
Okay. So these are the first angios. Put a wire. We have through the multi-track. We make injection.
What wire is that you're using, Mark?
Sorry.
What wire?
E-wire. An E-wire is something like a Lunderquist, and it's a pre-bended. I like to pre-bend them. It's my experience, if you don't pre-bend them, they tend to come back. And if the guy who is watching the groin doesn't pay attention, the wire just can come back. If you pre-bend them, they stay nicely in place. So this is the outflow tract over here. And so typically what we will do is interrogate the outflow tract. Now, in Belgium, we were committed until recently to the Melody system itself. And as you know, the Melody system, if you put it at 22, it's 24 outer diameter. So we are using here a 25 millimeter balloon. If I wouldn't see anything encroaching on a 25 millimeter balloon, it means that the outflow tract is way too big for a Melody system. And here you see some action. So it's a very low pressure. I mean, it's an atmosphere a little higher than that. Definitely not fully blown, because if you fully inflate the balloon, it would fully go up and you wouldn't see anything anymore. Looking at different angles, here's some encroaching, here's some encroaching. This is inflation of the balloon. It's also very, you see, when it's fully inflated, there is no ways to see nothing. Here's the deflation, and you see as you deflate the balloon, rather fast, you see the encroaching coming up. And so we always, in these patients, check for coronary artery compression, or the likelihood for it. I must say, in this subgroup of patients with huge outflow tracts, we've done now 30 so far. I mean, the coronary arteries are never a problem. They're way out. We're actually happy that the stent stays in place and doesn't fly away. So based on these issues, we could say, do we know enough to proceed, or do we stop the procedure, or do we proceed with prestenting?
Dr. Helen Brand, Bill, come on. Is that Evan as well?
We would use a slightly bigger balloon so I can see the waist a little bit better, because sometimes it's hard to see it if I use the same size balloon. But I would, based on that, we would probably plan on putting the Melody in on a 24 bib, on a 24 system, and probably plant the stent either with a 25 or 26 millimeter balloon, trying to establish good position with the stent, and then probably keep a little bit of waist if we can in that. Or if it goes up to 26 or just short, we'd probably put the Melody on a 24 bib. Do that. We would replace the ensemble system, put a 24 bib inside the ensemble system.
That's without pre-stenting.
No, I would pre-stent first. I said I'd put the first stent in first, be sure I have good position with the stent, trying to put on a 26 balloon probably, and then if we had a little waist inside, that was fine. Not try to get rid of the waist and put the valve inside the pre-stent. Probably put a 40, maybe even a 50, but probably a 40 stent. 40-014 stent, and then deliver on a 24 balloon if I was going to use a Melody.
Bill, can you tell us what size sheath you put up to deliver the 24 bib, or the Melody on a 24 bib?
You don't need a sheath. I put it to 20. I take the ensemble, take out the 22 balloon, cut it, and put the 24 balloon inside the ensemble system, but then use a short 22 French sheath to put it in through, with the balloon extending out beyond the end of the top of the ensemble system, because you have to cut off the carrot to switch the balloon.
Evan.
I would echo a little bit what Bill says, although I know Mark has a huge experience with this, so I suspect this comes out just fine. But we've moved away from using Tyshek and ZMed in these native outflow tracks to using ASD sizing balloons, usually a 30. Because what you're really trying to do is just really outline the outflow tract, which is very dynamic. So even if we see, we tend to get a much clearer waist with those bigger low-pressure balloons than we do with the others. RV pacing helps also to keep everything stable. And then I suspect you would see a really clear waist on an AST sizing balloon and then proceed much as Bill said, and either use a 26 Sapien or a Melody on a 24 balloon, which is the same OD, a 26 millimeter OD.
Can you tell us maybe just what waist on that sizing balloon you would not proceed beyond, or what diameter you would be reticent to move forward with?
I would just reiterate, pacing is a great help for us doing this procedure with a wide open outflow tract. So we always pace with this, and if we had a waist greater than 24, we would probably abort at that point in time.
We've pushed it just a little bigger than that, because if you think about it, the OD on the 26 Sapien or the Melody on a 24 bib is 26. So generally, if we have a waist that's less than 26, so we've done a few that are 25. There, again, I'm talking about the bare metal stent part, and our feeling is if we embolize a bare metal stent, we can probably deal with that complication. It hasn't happened yet, but we have found that if you have a waist less than 26, and the more less than 26 it is, the better, we're safe putting in a bare metal stent. They do go up all the way, there's no waist, and then you end up with a 26 outflow tract. But as you know, there's recoil on everything, and the two valves seem to stick into that.
Can I ask you a question? What stent do you use?
We use one of the large palmas, so usually the 4 centimeter long. I'm going to show a case at lunchtime that's about 3D modeling, but in those cases, when we do them hybrid through the apex, they're generally older patients, and we use the 5 centimeter long extra large palmas. For these cases, because the outflow tracts tend to be long, even though in Melody cases we mostly use the 3 centimeter long palmas, in these cases it tends to usually work out to be the 4 or sometimes the 5. But this is just a little kid, so I suspect 4 centimeter long.
I must say our experience has been, I've been very concerned with the large outflow tracts when not using a covered stent to pre-stent because of the risk of paravalvular leak with the Sapien valve. So we'll get like a 10 zig CP covered stent and use that, so the covering, you have better coverage at larger sizes. You can cover larger sizes.
That might be a great choice, except we live in the United States.
I know, my condolences.
Another question? You need to push down on the little button.
Dr. Atif Sahari from Saudi Arabia, Prince Sultan Cardiac Center. If I have Edward valve, I will go ahead with the Edward valve. But if I don't have it, and only Melody, so I will go with a stent over 26 balloon, and then keep it over for 3 months for better endothelialization, and then I'll bring the patient back. Of course, you can put the first stent over 26 balloon. You can put 3 stents or 4 stents to make it smaller for the Melody, or you can even using the gelling technique.
Thank you. Mark?
Okay. Well, just to give a quick answer, the reason why I use a 25 Tashak is if you inflate the 25 Tashak, you have a visual control what is 25. If you use a 30 millimeter sizing balloon, you have to rely on the measurements of your cath lab. And an error of 10 or 20% is very easily made. But 10% out of 25 millimeters, 2.5 millimeters, that is a disaster. So it's just to have a visual control. That's what I like about the 25. Good. Just as a little side thing, here a patient where we did see some indentations. This is another patient. And if you need some additional information, what also can be very helpful is make an angio through the sheet, so we use the sheet in that patient. And as you can see, this patient, he would end up with a very significant paravalvular leak. So in this patient, we did abort the procedure, but not in the one that I'm discussing right now. So the patient, the 12-year-old, we proceeded with a bare stent, open cell technique, and we like the open cells because as the stent is opened, those open cells will act as scalps and hook onto anything that you will have in the outflow tract, and that's exactly what you want to have. It's on a 24 because we know that we can over-push it a little bit, and again, the bib technology is nice to open up those large stents. I've seen with single balloons, stents being crushed as they were opened. However, a 26 bib, for instance, will need a 16 French sheet. And there's a big difference in maneuverability between a 14 and a 16 French sheet.
Mark, just coming back to Eric's point about a covered stent, I know you've previously advocated using the covered CP stent and had them actually fashion made for you. Why did you choose a bare metal here versus a covered, or did you have any thoughts on that?
I have nothing to prove. I didn't do a serial testing, but in this case, what I want to get is a landing zone with a stent that encroaches onto anything. The covered stent, by definition, will have nice covering around it, and it might slip. Whether it will slip or does slip, I don't know. I'm really eager to see on the experience of other people using covered CP stents. But it gives me, sometimes, you will see that the case, sometimes the stent will only hook onto the back of the original valve on a scalp, I mean on the open cell. And I'm aware of closed cells stents that have embolized. I didn't see the images. I don't know whether it was inappropriate technique or too small or because it was a closed cell. But it gives me an extra reassurance that you have an open cell.
Dr. Giovanni, you've got experience with the Andra stent. Would you use the Andra stent in this context, accepting that you were doing the case in the first place, but you voted for surgery with both hands, we noticed?
Yeah, I agree. I think that the Andra stent gives you the grip because of the design. The other thing about the covered stent is it's covered with Gore-Tex, so that's a little bit slippery. So the chances of it actually moving may be a little bit higher. And I think as far as surgery is concerned, I think unless there's a contraindication for surgery, it's not an unreasonable option either. But, you know, I would agree with the Andra stent.
Okay. So this patient was, just also as a side thing, what you have to realize that the stent will lock into the wall only at the very end of inflation. And here you see in another patient where we had inflated over here the inner balloon. Take this as a reference. By the time the outer balloon expands the stent into the wall, the tip of the balloon typically will have pushed back from the bifurcation the stent backwards in the outflow tract. In other words, you always end up more proximal with your stent than you aimed for, almost by definition. So here we proceed in the patient. Allow me to, so it's ready to go. And so this is now the image at full inflation. I must say, just having a visual control, it looked a little bit smallish to me. And so during the same inflation, so without deflating the balloon, I made an extra injection through the sheet to see whether I was in a nice position. So at this time, I'm at 24 millimeters with the bib balloon. And what you can see is, I mean, it is touching here and there, but still there's more contrast going around the balloon than you would like to see. Any suggestions at this moment?
Eric?
Tom Jones?
Remeasure?
Wait, at this point, so this is the initial inflation, so the patient is now in a no-flow situation, except for the small whatever leak.
Yeah, I don't know. I think you can come down with the balloon, because you have to come down with the balloon. You leave the balloon in place, do not move it, and make some assessment as to whether you have some stability. And if you don't, you puncture the other groin, try and cross over, put a second balloon in, and then try and expand it further.
Tom?
No, I was going to say the same thing. You know, you obviously.
Microphone.
Excuse me. I thought similarly. I think I'd be concerned about trying to withdraw that deflated balloon, and would probably go ahead and do exactly what Eric suggested, and try to attempt to either stabilize the stent with an alternate sheath system, or pass a second balloon alongside. That's even a better idea.
Thanks.
Okay. Well, here I think it's then very interesting that you thoroughly should know the characteristics of your balloon. So indeed, when you inflate a balloon, what you would like to see is either an indentation or that all the scalps open up like this, because that means you have been touching the wall and that you're hooked into the wall. When you see that, you're on safe ground. Now, so I didn't see that in this patient. What I simply did was overinflate the balloon. Yeah, a 24 bib, if you know, look at this. This is operating pressure. In order to get to 24, you go to 2 or 3 atmospheres. However, you can easily push it up to 5, and that will bring your balloon up to 25, 26 millimeters. And so that's what we did, simply overinflating the balloon. This is 24. It's exactly the same round. You can see you can stretch it, the stent easily up to 26. I've done this now over 12, 13 times. I've only had one balloon rupture, which was no problem whatsoever. I mean, the balloon could easily be retrieved. Here is then, so now the stent in position at 26. We make a little angio, and as you can see, I mean, it's touching the wall on most places. This is a little bit reassuring. There's almost probably no way that the stent will be able to make this corner over there, so it looks nice in place. And now the key issue is to remove the bib. I think that is the most tricky and the most dangerous part of the whole procedure, is take out your bib balloon, because it will encroach onto anything. And watch the stent as the balloon comes out. You will see that it will jump back, just suggesting how much tension you put on that stent at that moment. As a side thing, once in a while, in 3 patients so far, I preferred to come up with another wire, put the wire through the stent, put another sheet in the stent and push on it, then even take away the wire out of the bib balloon so that it wouldn't push too much on the side, and remove like that very gently the original bib balloon while pushing with the other sheet the stent against the wall, and in that way slowly, safely, and in a controlled manner remove the bib.
There was some, Mark, mention about pacing earlier on. Have you used it? Do you think it's valuable in this setting or scenario? Obviously not to take the balloon out, but when you're just trying to implant the stent.
I must say that when you use a stiff wire, you have the sheet, you have the balloon, the whole system is so stable that the blood flow doesn't bother me that much. What bothers you, I mean, what will push back the stent is the bifurcation, not the heart. It's not the beating heart. And again, as a side, that was the one patient. If you see, here was the stent when we inflated the inner balloon. So this is not this patient, but another one. This was the place of the stent after inflation of the outer balloon, and this is after removal of the bib balloon. You can see that you're losing some distance. I mean, this stent was nice and remained nice in place, but just to give an idea that removing the bib can be a problem. And so at this point, we now have the 43 Andra stent, which will have shrunken down to 36 something at 26 millimeters. Now, typically, we will leave this stent for 2 months in the outflow tract, so it gets nicely fixed. Now, why 2 months? It's just my wet finger that told me. From experience in dog experiments, I know that within a month, stent in the heart, whatever it touches will be overgrown. And so I took an extra safety of 2 months, and so far I've never had problems. We first crossed the stent with a tipped balloon, because otherwise you will not find the correct hole. As you see, 2 months later, the stent is still in nice position. But so now we have some calculation to do. As I said, we are committed to the melody. The landing zone now is at 26 millimeters. The melody will have an outer diameter of 24. If you overinflate it slightly, it will go to 25. So we're 1 millimeter short. These are the options. Either overdilate the melody, but accept some possible increase of pulmonary regurgitation, change of valve system, or decrease the landing zone. Any suggestions?
I would not use a sapien without a covered stent. I think in this type of outflow tract, because the stent is short and because you don't have very precise control, you get a paravalvular leak. So unless you're prepared to put in like a large covered stent, I would take sapien off the table personally.
So you first put a covered stent in, and then a 26 sapien.
29. Or 29.
29.
Yep.
So my problem is we don't have the 26 reimbursed, and 29 is out of, I mean, is even worse in Europe for the time being.
Well, my condolences.
The what?
My condolences, like the United States.
So Mark, you're saying, what's the thing about the 26 sapien? It's not reimbursed.
At that moment, it was not reimbursed in Belgium. I was committed to Melody.
Okay.
Okay. So what we did was decrease the landing zone. So here you see we re-enter the stent with a 14 French cook sheet. And this turn here is a little bit tricky. As you can see, the wire pusher was not doing his job very well. It was me. But the sheet came in. As a little side story, here you see what can happen sometimes when you try to re-enter the stent, and if this is not good, you can crush the stent. You can crush it badly, and that may make it impossible to use that angle to re-enter the stent. You will have to change pulmonary artery or come from jugular. But I mean, it always can be overcome. So in this patient, then we deploy a covered CP stent with its primary reason to decrease the size of the landing zone. And we chose here to put the stent as proximal as possible, not to get any infolding at the time when we would proceed with the ensemble system. So here the stent is deployed in the outflow tract, and I think now we come with the ensemble system. So it's on a regular 22 millimeter system.
Did you do any measurements to see what the stent diameters were? Were you happy that the 22, say with a 24 outer diameter would be enough for you now?
No, as I say, I believe more my balloons than I believe the measurements of my angio system. And I've been doing proctoring on quite a few places, and you cannot believe the error people make in measurements. And here, 1 millimeter wrong or 2 millimeter wrong is very important. So the melody is in place. Here we were aiming for delivering the ensemble system, or the melody at the distal, and it's just for the fun. I mean, we always try to make up our mind where are we going to put it. And
What's the opacity in the center of the screen there?
The arm. So I keep the arms next to the patient and limit the fluoroscopy as much as possible for radiation. That gives me, I mean, doing that, I have the arms are not in the way. I can go cranial if I want to, and it gives a little bit more radiation.
The arm looks though it's in the way to me there.
Yeah. Here the stent is deployed, and so now we have the melody again. So that the ensemble of 22 can be slightly overpushed, and what you have to aim for is approximate the melody stent against the previous stent. Here just angio to make sure that everything is all right, and that is then here the final result. So how does it look like? The other things, valve function was perfect without any regurgitation. So this valve was actually opened at 22 plus, about 23 millimeters. Next day, the right ventricle already had resumed significantly, and here you see pre and post. This is 3 months after implantation with good valvular function and already significant regression of the right ventricle. Indeed, we can discuss about opportunity or indication of doing it early. One of the points we also have to consider that the goals of the current guidelines are that if you follow the current guidelines, you will have shrinkage of the right ventricle. I think the thing that our patients are asking us, however, is that they have a cardiac event-free life into old life, up to 70 years old. And none of the guidelines so far has proven superiority of either technique. So I think we have to keep our minds open. Indeed, doing it earlier may mean that on a lifetime, these patients may need one more valve, but even that I'm not sure of that it doesn't mean automatically one more valve.
Mark, that is an absolutely outstanding result and a good lesson to many of us how you can push the envelope a little bit when the chips are down in terms of dimensions. Thanks very much indeed. Great case.